Hello, everyone, and thank you so much for joining us. This is Georgie Carter from the Health Policy Plus project. I'm delighted to welcome you to today's online policy forum entitled Quality versus Coverage. Is there a trade-off in financing maternal health? We have a great discussion lined up for you today, and we'll begin with just a few announcements. So this session is being recorded, and we'll be posting the recording on the Health Policy Plus website. We would love to hear from you and we welcome your questions at any time. Please submit your questions via the chat box on the right side of your screen, and our moderator will read them aloud when we pause for questions. Now, these web conferencing platforms are getting a high volume of traffic these days, so we ask that you bear with us just in case there are any glitches with the technology. And then finally, we ask that if you are not speaking, please mute yourself to keep the line nice and quiet while others are talking. So that concludes our announcements portion, and it is my pleasure to hand over to my colleague, Elena Teva, the Advocacy Manager at White Ribbon Alliance and our Maternal Health Lead for the Health Policy Plus project. Elena?
Thank you so much, Georgie, and welcome everybody. Good morning, good afternoon, and good evening, wherever you are in the world. My name is Elena Teva, and I will be your moderator today. I work with the White Ribbon Alliance, a global advocacy movement for reproductive, maternal, and newborn health and rights. As Georgie said, we are the lead maternal newborn health partner on the Health Policy Plus project, supported by the United States Agency for International Development. Today's discussion focuses on an impossible dilemma. Do we direct resources to ensure that most women can access maternal newborn health services close to where they live, recognizing those are going to be of varying quality, or do we focus on fewer facilities but ensure the best possible quality? This discussion will focus primarily on coverage and quality regarding childbirth services. However, this is far from the complete policy picture regarding maternal health. We know that ending preventable maternal and newborn deaths must also take into account social and structural determinants such as equity, human rights, and women's status in society. As we think about critical choices in maternal health financing, let's ensure we think about leveraging multi-sectoral investments to ensure the whole maternal health journey is supported well before there is an emergency, so that we don't have to make trade-offs with women's lives. It is my absolute pleasure today to introduce today's presenters. To set the stage for our discussion, we have invited Dr. Alison Morgan from the Global Financing Facility based at the World Bank. Prior to joining the GFF, Alison was an associate professor at the University of Melbourne, Australia, where she led the Maternal, Sexual and Reproductive Health Unit at the Nassau Institute for Global Health. She has 30 years experience in global health research and development practice, with a focus on maternal and newborn health, quality and metrics, health system strengthening, and capacity development of health workers. She was a founding member of the Safe Motherhood for All, a White Ribbon Alliance equivalent in Australia. Welcome, Alison. Next, my colleague, Dorit Stein, will focus on how health financing can improve quality of care by sharing some of our research from Indonesia. Dorit is a health financing associate at Palladium, mainly working on the Health Policy Plus project. She holds a Master of Science in Global Health and Population from the Harvard T.H. Chan School of Public Health, and has a range of experiences providing evidence to support health and science policy decision-making domestically and abroad. Very nice to have you here, Dorit. Dr. Nana Danso from the Rockefeller Foundation will share the latest evidence from the Lancet Commission on High-Quality Health Systems. Nana is a public health and preventive medicine physician with 20 years experience in health policy, practice, strategy, monitoring, learning, evaluation, research, and philanthropy at local, national, and international levels. She's also an adjunct assistant professor at the Department for Maternal and Child Health at the Gillings School of Global Public Health at the University of North Carolina, Chapel Hill. And finally, my colleague, Dr. Aparajita Gogoi from the White Ribbon Alliance in India, will tell us what women want and how women define what quality means to them. Aparajita is the national coordinator for the White Ribbon Alliance in India. She is the executive director also of the Indian NGO Center for Catalyzing Change. Aparajita is a political scientist with 25 years of experience in programming, advocacy, and defining strategy for policy issues, especially on young people's health and rights. She's passionate about women's health issues and has been an advocate for safe motherhood, firmly believing that surviving childbirth is a fundamental right of every woman. Now I will turn it over to Dr. Alison Morgan to start off the conversation.
Thank you, Elena, and good morning, good afternoon, good evening, everybody. It's great to have the opportunity to reflect on what is a really critical question: quality versus coverage. Is there a trade-off in financing maternal health? This is a question that we grapple with at the Global Financing Facility, which many of you will know is a multi-donor trust fund. Next slide, please. Supporting 36 low and middle income countries to accelerate progress for transformational change across reproductive, maternal, newborn, adolescent health outcomes. At the core of our work is a country-led process to develop an investment case. This very decision addressing this challenge on how to ensure that limited resources are deployed to give the best health outcome. So is there really a trade-off between quality and quantity? On one level, it's an age-old question that's challenged those providing care for women during childbirth for decades. And while the easy response is to say this is a pretty false dichotomy because care without quality is not care, the Lancet Commission on High Quality Health Systems in 2018 was very illuminating. Poor quality is a greater problem than lack of access, and there's a potential to prevent about 200,000 maternal deaths and 1 million newborn deaths each year just with better quality care. Next slide, please. So it's worth examining the particular situation for maternal health that gives context to the question we're discussing today. We learned soon after the 1978 Alma-Ata Declaration that primary health care without an accessible referral pathway provides limited life-saving potential for women who have a serious complication during childbirth. Main and Rosenfields articulated that with their seminal 1985 article, arguing for a rethink as the PHC approach had not changed maternal health outcomes. So by the time we launched the MDGs in 2000, we thought we knew the answer. Increasing SBA, skilled birth attendant coverage, would yield the target of a 75% reduction in maternal deaths by 2015. Yet we learned over the MDG period that focusing on quantity, or what we might call crude coverage, of interventions that we know save lives, does not lead to the health dividends we hope for. Many countries saw an exponential rise in the proportion of women having a skilled birth attendant at their birth, and yet the number of maternal deaths did not reduce as expected. You would imagine that most countries would celebrate reaching, for example, 90% of births being with a skilled birth attendant. Yet we see across the world today, MMR's maternal mortality ratios of up to 378 in countries with that sort of SBA coverage. There are 89 countries globally that have a skilled birth attendant coverage of over 95%, 95%. And yet their respective MMRs vary between 2 and 144. And with a global target of 70 for the SDGs, we cannot rely on this coverage target alone. So we need to shift from moving from crude coverage to effective coverage, where effective coverage incorporates that component of quality care. So where does that leave us? I think there are two particular biases that play out in addressing maternal mortality in low and middle income countries. The first is what I would call a confirmation bias. Most women having a baby do not have life-threatening complications during their birth. So the difficulty is that this means that women having a normal pregnancy, labour and birth may well survive poor quality care, which can then in turn reinforce that poor practices. Poor quality care is exposed when things go wrong. Consequently, there is an implicit assumption that because usually things work out, then the emergencies are outliers, and if the outcomes are poor, then that's because it was an exceptional circumstance rather than a poor quality care. The second bias is what I'd call incremental system bias. We like to have a neat solution. It's a characteristic that makes challenges difficult for addressing maternal deaths because we need system to be functional. In contrast to child health improvements, maternal health is not something that you can tackle one intervention at a time. Individually scaling up immunisation or vitamin A or IMCI will each make a measurable, appreciable difference to overall child mortality. But for maternal deaths, that doesn't work. It is not enough to just ensure that a woman receives a uterotonic drug during the 3rd stage of labour, although that's a really important intervention to be sure it happens. But you also need to know that should she continue to bleed, there's rapid access to fluids, blood products, potentially surgical interventions, if you're really going to save her life. Similarly, for a case of eclampsia, it's not enough to have magnesium sulfate in stock and a nice protocol on the wall for how to administer it. Are the staff also in a position to ensure a timely birth, to care for a potentially small and premature baby? Our focus on single interventions, which works for introducing, say, another vaccine to the EPI program, doesn't work for an obstetric emergency where the referral and clinical care needs to be available 24/7. And we know that obstetric emergencies are usually not able to be well anticipated. If you only have parts of that system in place, and it doesn't matter how high quality those individual interventions are, if the supportive system isn't functional, you're not providing quality care. Hence the dilemma. When resources are limited, the choice, I believe, is not do I tone down the quality of the care I'm providing? Rather, it becomes a question of prioritisation. How do I ensure that this 24/7 network quality system coverage is available to the highest proportion of the population while working towards more accessible and equitable coverage for everyone? So this is where our presenters today are going to give some really helpful insights. And so it's my pleasure now to hand over to Dorit Steen on the health financing team at Palladium to set us going. Thank you, Dorit.
Thanks, Dr. Morgan. Good morning and good afternoon, everybody. My name is Dorit Steen, and I'm an associate on the health financing team here at Palladium, working mainly under the Health Policy Plus project. Next slide, please. I'll start by showing the breadth and scope of our health financing activities under HP Plus for maternal and newborn health, where our main objective has been evidence generation to inform efficient delivery of high-quality M&H services. As part of one of these domains, in coordination with USAID and Indonesia's Ministry of Health Center for Health Financing and Insurance, we conducted a study to support strategic purchasing reforms for M&H services in Indonesia, focusing on understanding whether attributes of fund flows for maternal health services may influence provider behavior and quality of care. Today, I'll present some of the key findings and policy recommendations from the survey and analysis, but not before acknowledging the work from my colleagues and other co-authors in DC and Jakarta, including Jorge Ugaz, Fajar Ahmadi, and Arin Dutta. Now, a bit of background and rationale for this study. Next slide, please. Similar to many countries, maternal mortality in Indonesia remains high, and it has not improved much in the last 2 decades, even though more women than ever are delivering in health facilities, pointing to likely deficiencies in the quality of maternal health care and referral systems in the country. So what is the role of purchasing, and specifically strategic purchasing? Strategic purchasing of health services is a policy tool available to influence the efficiency and quality of health service delivery, and includes decisions around what services to purchase, from whom, and how, and requires developing a coherent set of incentives across all funding streams that motivates providers to efficiently deliver a high-quality benefits package that aligns with health system objectives. More efficient delivery of high-quality maternal health services, in addition to improving outcomes, can also free up more resources that can be invested in improving and expanding population coverage of M&H services. With the implementation of one of the world's largest national health insurance schemes in 2014 in Indonesia, there is huge opportunity for more active and strategic purchasing to contribute to improving health outcomes, and maternal health care is one of the priority areas for strategic purchasing reform in the country. But in Indonesia, like in many countries, M&H providers receive funding from multiple sources or multiple funding flows, as seen in the figure on this slide. This means that providers are paid by many different payment mechanisms with varying attributes that may influence provider behavior. These attributes include things like, for example, the flexibility of funding, sufficiency to cover direct costs, predictability in terms of timing and amount of payments, and complexity of reporting requirements for any given fund flow. And in order to design a coherent set of incentives for M&H services, it's necessary to try to understand how these multiple funding flows with their varying attributes interact at the facility level to influence provider behavior, quality of care, and ultimately health outcomes. Next slide, please. Our main research question was, do multiple funding flows for M&H services incentivize the provision of high quality care among primary and secondary care providers? To answer this, we conducted a survey among over 100 providers across the country and looked at the association or relationship between facility capacity to provide high quality delivery care and provider perceptions of fund flow attributes, including the flexibility of funding, sufficiency of national health insurance payments to cover direct costs of providing M&H services, and the autonomy of providers to make management and service delivery decisions, known as decision space. Next slide, please. Now to summarize some of our key findings. First, we found low capacity to manage obstetric and neonatal complications among primary care providers in our sample. This mirrors evidence across the world of low quality care being provided to women who deliver in lower level health facilities. In our sample, all of the primary care facilities with inpatient beds that were supposed to be basic emergency obstetric and newborn care or BMONC capable were not actually BMONC capable using international definitions of the signal functions BMONC facilities should provide. Next, when looking at the flexibility of funding, we found important differences between provider ownership status, wherein public providers rated their revenue as more limiting to use than private providers, mainly due to the inflexible input-based revenue that public providers receive from national and subnational government budgets. In terms of insurance payment sufficiency to cover direct costs for M&H services that providers provide, we found that primary care providers rated their fee-for-service payments for M&H as less sufficient to cover direct costs compared to the hospitals we surveyed. We also found that local governments are not allocating enough funding for referral transportation, and often those costs are passed on to women when being referred, especially when they are back referred from hospitals to primary care facilities. This perceived insufficiency of payments and low capacity at the primary care level could lead to increased up referral from primary care facilities to higher level facilities in the country, which both increases costs to the system and to women and contributes to overcrowding in hospitals for services that could and should be by design provided at lower levels of the system. When looking at the association of these funding attributes with the quality index we constructed, we found that greater autonomy to make management decisions was associated with higher capacity to provide high-quality delivery care, even after controlling for provider characteristics and geographic distribution. Next slide, please. From these findings, we developed policy recommendations with selected recommendations shown on this slide. Given the low capacity of primary care providers to respond to obstetric and newborn emergencies, we recommended that women be encouraged to deliver in higher level health facilities where possible until capacity improves at the primary care level. Relatedly, we recommended that primary care capacity to provide high quality M&H services be improved and insurance payments for M&H be adjusted to better cover direct costs, which may help rein in unnecessary up referrals and reduce costs to the system overall, while providing quality care to women near their homes. And lastly, we recommended that budget from national and subnational fiscal transfers for public facilities be made more flexible and that autonomy of facilities to make decisions be increased so that providers are empowered to respond to incentives and have the managerial autonomy to use their resources to respond to the needs of the populations they serve. Overall, we hope our findings would help to streamline incentives for M&H providers in Indonesia. We also hope some of these key findings can be applied in other countries with mixed provider payment systems. Next slide, please. I've shared just a portion of our analysis and findings, and more detail, if you are interested, can be found in 2 policy reports that are available on the HP Plus website in both English and Bahasa. Thank you for your time, and please feel free to email me with any questions you may have that we don't get to during the discussion later on. Now I'll turn it over to Dr. Nana Tumdanso.
Great. So my portion of the presentation is going to talk about how do we turn the tide on maternal neonatal death, specifically in Sub-Saharan Africa and South Asia. Next slide, please. You'll see a map of the world showing up very shortly, where you'll see that the overwhelming dark colors on the map, where the maternal mortality ratio is highest, is in Sub-Saharan Africa and South Asia. And together in 2017 globally, there were almost 300,000 deaths, and 86% of those deaths were in Sub-Saharan Africa and South Asia, where the dark purple colors you'll see represent maternal mortality ratios of greater than 100, whereas the other parts of the world, maternal mortality ratios are less than 100, in some places even less than 10. So you can see that Sub-Saharan Africa and South Asia are falling behind. Next slide, please. The next slide looks at what has been happening over time. The previous slide was a snapshot in 2017. This one looks at a 2.5-decade period from 1990 to 2015, where you can see number of maternal deaths. And you'll see that Sub-Saharan Africa is represented in the blue, South Asia is represented in the aqua greenish color. Overall, globally, you can see the number of maternal deaths has reduced dramatically over the 25-year period. South Asia as well, the number of deaths have been improved dramatically. Sub-Saharan Africa is the only region that's lagging behind in terms of number of maternal deaths, even though the ratio, the MMR, has improved in some parts of Sub-Saharan Africa. Next slide, please. And the third slide on maternal deaths I'm going to talk about is really the medical causes. What is killing these women? And as you can see, this is a graph that shows the causes of death across age groups, starting from age 10 all the way to age 54. And the y-axis is a percentage. So the orange color, kind of rust, is maternal hemorrhage. That's the most common cause of death across all age groups. And the reddish color is maternal hypertensive disorders such as preeclampsia and eclampsia. The light orange color, also important, a percentage over the age groups, is maternal abortion, miscarriage, and ectopic pregnancy, any of which actually need emergency medical management. So maternal hemorrhage, maternal hypertensive disorders, and miscarriage, ectopic pregnancy often need some kind of emergency medical services, such as that found in a CMOG facility. Next, please. Switch to newborns. The reason why women in this vulnerable position in the first place is that they're having a baby, or they would like to have a baby. And so it's important to recognize that almost 50% of newborn deaths actually occur on the first day of life. Depends on the country, can be as much as 40, as low as 40%, it can be a bit higher on the first day of life, and most of them happen around the time. So it's important when we talk about maternal deaths to almost always combine the newborns, because the dyad is at risk at almost at the same time. So this map of the world again shows Sub-Saharan Africa and South Asia in darker colors, the orange, the reds, the yellow, and the rest of the world essentially in blues and a little bit of yellow. And in Sub-Saharan Africa, you'll see that the newborn mortality rates are much higher than 20 neonatal deaths per 1,000 live births, whereas in the rest of the world is much less. And next slide, please. And the causes of death for the newborns, the most common are prematurity related or intrapartum accidents or asphyxia related. Together, those two causes of death represent 60% of the neonatal deaths. Oh, next slide, please. Yeah, and it's important always to look at time, right? So the previous slide again was a snapshot. Over time, it's important to recognize that the world has made huge improvements in under 5 child mortality. As Dr. Morgan said at the beginning, a lot of the improvements are related to increased coverage of immunizations, increased management of respiratory infections like pneumonia, and diarrheal diseases, improvement in sanitation and water, etc. But neonatal mortality has not improved as dramatically as infant mortality or for children under age 5. You'll see with the newborns, the good news is that the complications due to preterm have reduced by more than 50% over time. Again, this is the same 25-year period I referred to earlier. Whereas newborn deaths related to trauma at birth or asphyxia, unfortunately, you'll see the line has barely reduced over the 25-year period. It started out around 900,000 in 1990, and it's barely below 900,000 in 2015. Again, these are numbers, not rates. Next slide, please. So as we think about these deaths, the numbers that haven't reduced as much as we'd like, as well as the causes of death, we have to narrow down on where are these women dying, what are they dying of, and what can be done to reverse this trend or accelerate the improvements. And really, almost all of it points to what both Dr. Morgan and Dorit said at the beginning, is around CMON care, right? So how do we get to a situation where every woman, regardless of where they live, regardless of their socioeconomic class, their tribe, their geographic region, has access to a comprehensive emergency obstetric and newborn care 24/7? Because these are the most common causes of death: the hemorrhage, the hypertensive disorders, the preterm complications, and the intrapartum asphyxia of trauma. And for a lot of the newborns who have these conditions, the window for action is literally a few minutes, maybe an hour or two soon after birth, to reduce the risk of morbidity and mortality. So what happens if the newborn is born in a facility without CMOG, or the mother suffers a uterine rupture, or some kind of tear, genital tear that cannot be sewn up at the primary care level, needs blood transfusion or needs surgical intervention to repair the tear? What happens, right? So a lot of that is where we're concerned that the system fails the women and children. It's not about specific interventions, as Dr. Morgan says, it's about the system in place. So let's say, for example, there's a country that has a million, let's say a relatively large country, 30, 35 million people, there's 1 million births per year. Let's say 10%, in some countries 10%, maybe 12% of births end up in complications. And we know that not all complications can be predicted. In fact, some women, 30% of women who are determined to be low risk during antenatal care can develop complications during the process of birth. So let's say you start out with 1 million births per year, 10% of them have complications, that's 100,000. Let's say 50% of those births occur in primary care facilities, whereas the other 50% occur maybe in towns or cities where there's a relatively robust hospital system that has the CMOG capabilities. Of the 50,000 that occur in primary care facilities, there's going to be a proportion of them that can be saved at that level through the actions of the providers at that level, heroic efforts. I mean, we've all seen midwives doing everything they can to save a life in spite of limited human resources and equipment and supplies. There will be some that, no matter the heroic efforts made at the primary care level, will need to go to the next level. So then you have to call for an ambulance or other type of transportation, and you have to cover 2-3 hours of roads or in a remote area to get to that definitive CMOG care. What are the chances of a premature baby who's having difficulty breathing the first minutes of life surviving that 2-hour journey? What about a woman who suffered a severe hemorrhage needing transfusion? So I think next slide please, as we think about these scenarios, and they're not rare, 10% of anything, let's take COVID, right? If maternal deaths were a newly discovered medical condition that affected 10% of women in pregnancy, we would consider that an epidemic, and we'll be going through all kinds of innovations to try and find solutions. Unfortunately, maternal deaths, especially preventable maternal deaths, have been normalized so much that even though 10% of pregnancies have complications and a certain proportion of them will die, we don't treat them universally as something that needs our urgent attention. So one of the ways that we're proposing, this is from a paper that some colleagues and I from the Harvard School of Public Health, Harvard T-Chan School of Public Health, as well as Save the Children, published last year, is how can we move to a more equity-focused and equality-focused healthcare services at birth, so that every woman has access to 24/7 CMONC care at the time of birth. So one is to optimize as much as possible. So childbirth happens near or in a hospital that offers definitive care, C-sections, blood transfusion, all of that, intensive care for newborns who can't breathe or newborns who've been resuscitated, needing extra support. We know that that's hard. You need specialized human resources, you need equipment and supplies. But if that's what it takes to save the lives, let's optimize for that. In the meanwhile, the primary care facilities that used to provide childbirth care, in addition to antenatal, postnatal, how can we optimize them to provide better quality antenatal, postnatal, and essential newborn care for well babies, and potentially do other things that primary care facilities do. At the same time, we recognize that even if the health system redesigned itself to say childbirth should happen near or in health facilities, not all women may be willing to do that or be able to do that. Labor might happen too far away to get there, etc. So we still need to anticipate that some people will have to be referred and have to rely on emergency transport. So we need to invest in roads and ambulances to ensure that happens. We want to minimize that because we don't want to put an unstable patient in an ambulance, even in a city, even in a big city with good roads, we don't want to put an unstable patient in an ambulance. So we want to minimize that for remote rural areas. And then of course, all of this sounds very supply side. We want to make sure that the demand side is also attended to. Women and communities have to have high expectations of quality of care to make this viable. And then we need to also think about the political leadership and the political will and budget that ensures that this can happen. And I don't actually want to end my presentation with such a heavy biomedical view of this problem. I do understand that a lot of how we've gotten where we've gotten, where preventable maternal deaths are not as high on the policy agenda as they should be, I think it comes to some of the root causes of why this is happening. And I want to recognize that, if women had more regular, more affordable, culturally acceptable access to family planning, they won't have to take this risk of childbirth so many times in their lifetime. They may only have it 2 or 3 times in their entire lifetime, which reduces their risk. So access to family planning is important. We also know that maternal malnutrition as an underlying risk factor for all these bad conditions, especially anemia or even malnutrition in terms of the size of the pelvis of the adult woman being a risk factor. And then finally, we know about child marriage in some settings where we're having teen pregnancies occur in the context of marriage, where communities bless this marriage and this pregnancy, and teen pregnancies are higher risk. So if potentially child marriage could be abolished, pregnancy delayed until late teens, early 20s, where women are a little stronger, healthier, pelvises are a little bigger, we may not have as many of these. And then finally, women's agency and ability to choose high quality care, potentially to travel further if they wanted to access high quality care in a town or a city that was a little bit further from their homes. They need that agency themselves. So it's not just a biomedical solution, it's really thinking about how do we bring all the solutions together, the socioeconomic ones, the cultural ones, to address this equity and quality focus and redesign that we're talking about. On that note, I'll hand over to Aparajita. Over.
Thank you, Donna, so much for that. And what you spoke about giving women the agency to really decide and understand quality and seek care is where I will begin with. The next slide, please. So I have just put a couple of graphs which talks about where we are in India in terms of reducing maternal death. So if you look at the data, you will see that India has done pretty well. If you look at reduction in MMR, the decline in India in the last decade has been faster than the global decline, and many programs have led to this decline. We have good policies, budgets, there are many system strengthening efforts, there are conditional cash transfer schemes, to encourage women, incentivize women to come and deliver in the hospitals. We have better skilled providers, etc. But I think the question that we are talking about today is, yes, there is coverage, but is coverage really, has it led to commensurate quality? As you can see, we have today over 90% of institutional births, but our MMR is still at 113. So I'm going to take this conversation forward. So next slide, please. So primarily, when we are, talking about coverage, availability, accessibility, quality, the point I'm going to make today is that we really need to take into account women's perceptions about quality of care, not just their experiences, but also the perceptions. And we need to understand why would women want to access services, and also what makes them reluctant to access services. So what facilitates service-seeking behavior, and what are some of the actual barriers and perceived barriers when they want or do not want to access services. And I want to make the point that changing the picture must include understanding what women and girls want, especially, like I said, in identifying the barriers and solutions that we provide for healthcare. And I don't really have to stress that quality has a huge impact on whether a woman will actually go to seek family planning services or childbirth services or even antenatal and postnatal care. And from our work and research, we know it very well that these are the elements which really, really matter in service-seeking behavior, and many times matter more than distance or finances. Women may kind of, look at distance as a barrier to seeking care, maybe look at money available to seek care, but we all know that it's really, really important to understand that women, what they feel about quality, and then, how that really impacts the health-seeking behavior is something that we need to understand and unpackage. Next slide, please. So with this kind of background and understanding, we began the What Women Want campaign. This campaign was inspired by the notion that women's voices can and should be used as evidence to inform programs and policies, in addition to the other evidence that is taken into account when we make and design policies and programs. So under this campaign, each woman was asked just one question. What is your one ask, your one request for quality reproductive and maternal healthcare services? So this was, it was not like a survey, but it was a campaign, and we thought that it would be, kind of really, really good and quote unquote easy to get responses from women. But at the same time, we also felt that, this campaign could be an effort to provide a platform for women's voices and really enable them to unpackage, understand, and speak about quality of care. And the idea was that, how do we really amplify women's self-articulated needs, and how do we kind of amplify these voices that they really are taken into account when we are designing health policies, programs, and also talking about accountability. This campaign began in India and then went on to become a global campaign, and we reached out, I think, as of today, to over 1.2 million women across the world. And what I also want to add that this campaign was really driven by women's voices. It was not a sanitized version of what women's experiences are or demands are in order to please everybody. But we really built this campaign on the premise that women's voices are essential and necessary in order to understand not just quality of services, but also accessibility, availability, etc. And as you can see, women, of course, ask for access availability, but when you look at quality of care asked, respectful maternity care was the highest ask from women. And from this particular evidence, we went on to really talk about the importance of respectful maternity care. And today, if you look at some of our policies, our labor room improvement policies, maternal health assurance scheme, you will see that respectful maternity care today is in the center of our policies. The next slide, please. When we talked about, the global demand, as you can see from this slide, respectful and dignified care also emerged as the highest ask at the global level, but it also told us that despite the usual suspects, medicine supplies, skill provider, health sector to be open 24/7. Related elements like water, sanitation, and hygiene, how much that was important to women when we talk of quality of care or when they talk about quality of care. And I think this really pointed to the fact that we really need to go beyond our kind of usual suspect of kind of improving quality in terms of antenatal, postnatal, childbirth services, but how do we also look at related sectors? The next slide, please. This is just a couple of pictures. As you can see, women ask not just for services anywhere, but also services that could be closer to home, services in rural centers. Of course, more health providers like midwives, but also like I have been talking about during this particular presentation, how women really ask about, how service providers' behavior, how they're treated also matters a lot. Next slide, please. Of course, like I said, we have spoken to 1.2 million women, but I thought these could be some of the quotes to really best convey how women perceive quality of care and how they function, how they really perceive this, the coverage versus quality, and where do they stand in this particular conversation. As you can see from the first quote, a woman from Kenya is talking about how weak health system actually causes more damage, causes maternal death, and how difficult it is for women when they arrive at the facility, often after hours of labor, hours of traveling, and when they encounter ill-equipped health centers and poor quality of care, how they feel that this could be even more fatal. We have a woman from Nigeria who talked about, this is a common ask which has come across from multiple countries about availability of doctors, providers, suppliers, health center being open 24/7. There is a quote from a woman in Cameroon, from Mariana in Cameroon, who talks about having a maternity center closer to home. And I think when we are talking of referring, kind of shepherding women into higher levels of tertiary care, and then we also need to talk about how do we deal with this kind of ask of women wanting services closer to home. Then, of course, there is a quote from a woman in India where India really kind of it's a cashless childbirth kind of a facility in the health centers. But despite a cashless kind of a scheme, entitlement, when medicines are not available at health centers, what a woman and a family undergoes, and how having access to their entitlement is really, really vital for women. I think all of these quotes and the entire What Women Want campaign really points to the fact that if we are talking about improving access and quality, we must also fully and consciously incorporate solutions that are being proposed by women. Next slide, please. So I'm going to end with this particular slide, which talks about the launch of the What Women Want dashboard. Like I had mentioned, we have spoken to women all over the world, and on 25th March, this dashboard will be launched. It will be made public, and in this particular dashboard, you will be able to see responses from women and girls from across more than 100 countries. You will be able to compare and contrast between countries, between topics, and between age groups. You will be able to browse through the responses of women, theme-wise, what they have asked about, maternal care or about postpartum care, about better facilities. We can use filters and keywords to extract what would be most important for whatever policy we are making or whatever quality of framework that we would like to design. And I'd like to really end by talking about, just adding to the conversation that yes, we need many more elements to come together when we talk of improving not just coverage, but quality. And we need to listen to women in order to also drive our programmatic and advocacy priorities when it comes to quality. With this, thank you so much. And back to you, Alina.
Thank you so much, Aparajita, and to all of the presenters. We will start with a few questions, and please do post additional questions so that we may address them. We're really looking forward to the discussion. This is a complex problem that we're trying to look at from different angles, so we might have the benefit of all of the expertise that's here in the room and joining us online. My first question is to Dr. Nana Tumdanso, we know that clinical quality of care does not necessarily result in equitable care or culturally competent care. We know that the further women are removed from their communities, the more likely it becomes that they will be cared for by somebody who is quite different from them in terms of race or ethnicity or language, religion, and that introduces complexities. So how do we propose a system redesign that takes into account equity concerns? How do we make sure that, you know, inequitable care does not occur?
Yeah, it's a great question, Elena, and I want to start by, in many ways, looking at the root causes of why we have so much disrespect and poor attitudes towards some patients in the healthcare system. And I think a lot of that stems from societal values and societal values of those particular women, whether it's based on tribe or language or geographic area. So to address the equity concerns, especially the further women are away from their homes, I think we have to address the root causes of some of the reasons why healthcare providers feel that they can, quote unquote, get away with such disrespectful care. We've all heard stories about teenagers being treated so poorly in the health system because they're pregnant. And the fact that healthcare workers think they can scold or punish a teenager for being pregnant is a cultural value that I think as we think about this, we need to retrain our healthcare providers to really understand that the quality of care they provide should be the same regardless of the origin of the person or the language or so. It's not simple because these are deep-rooted societal values that are reflected in the health system. The healthcare providers are from the society. So whatever the society's poor behaviors are towards particular groups is reflected in the school system, is reflected in the health system, is reflected when we go to other government services. So I think this is a much tougher problem, but it's a societal one. And we need to ensure that every patient who comes in has human rights respected, regardless of who they are. And that's a societal change, and it starts from the top of leadership in the health system, as well as the bottom through agency of the women, as well as any companions that are with them. So during birth, women are their most vulnerable. If they're able to come with a companion who can be their advocates, who can be their eyes and ears when they're potentially being disrespected, that's one way to address it. But this is a long-term systemic solution, and it's societal, not necessarily a healthcare system problem. It's a societal problem. We need to stop the discrimination and the other things that are in the system, in the societal system that people get away with, I think.
Thank you so much, Dr. Tumdanso. The next question is for Dr. Alison Morgan from the audience. Are we unintentionally perpetuating the belief that quality and coverage are mutually exclusive when we use maternal deaths as the most important metric in maternal, newborn, and child health, especially when women rate disrespect and abuse as their primary concern during childbirth? If surviving childbirth is the primary measurement, it seems that we're missing a larger story around quality. What other metrics can we use?
Thanks. That's a great question, and I think it's we've often thought about how do we really measure the experience of care. We know that it's just as a critical component of quality care as the provision of care, but we've been slower to measure it because it's our current measures are through population-based surveys or HMIS data, and often we don't capture women's experiences so well in those routine data collection systems. So there is a real need, that is a real gap, I think, and a lot of people are exploring ways of doing exit interviews or follow-up interviews with women. There's lots of work around patient-reported experience, measures and outcome measures that are being explored both across lots of countries now. So that I think this is a space that we have grown into, and I agree, if we're just going on survival, for every woman who experiences a maternal death, there's another 20 to 50 women who have some sort of morbidity or disability as a result of that experience. And we know that there's huge preventable stillbirth and neonatal mortality that happens when if we just go on survival, we're not going to really address some of these quality issues. In reflecting on the respectful maternity care, I think the other concern is that we often don't give due respect to the health workers themselves, that a lot of them are under enormous pressure. They are women in the system who are often being treated poorly themselves, and it's very hard for them then to feel that their onus on them to provide respectful care when they themselves are not respected in the workplace. And I think we have to recognise this enormous health workforce shortage that we turn a blind eye to so often and just expect more of the health workers to do more. But coming back to your central question, I agree entirely. And I think that's why even if we just do some of these outcome measures on skilled birth attendants, we know that that doesn't work. If we're just looking at maternal mortality, I mean, that is important. We need to be measuring it. It's a real marker of inequity globally. But yeah, we do need to get beyond it to the routine measurement of the experience of care.
Thank you so much, Dr. Morgan, and thank you for focusing our attention also on the precious resource that health workers are. I think we've only just started realizing the importance in the past year when we were pressed by the COVID-19 pandemic. Continuing on focusing on health workers, there's a question for Dr. Aparajita Gogoi. Congratulations to WRA India and Dr. Aparajita for the tremendous work and success in reducing maternal mortality. Quality of care is so critical. How do we get health workers to care? What has worked in your experience? And is it about health workers caring, or is it about the larger systems around them, I would add? I think you're muted.
Thank you for the question, and thank you, Elena. I think this is a really critical question, and I think Dr. Morgan already began responding to part of the question. I think the first thing is that we really have to pay due importance to the kind of circumstances that under which the health workers are performing. So first, of course, we need to pay due attention to infrastructure challenges, HR challenges, because they do work under highly stressed, HR challenge circumstances. But however, having said this, I think in our 2 decades of work in India with providers, with communities, what we have realized is that a lot can be done when it comes to really orienting, training providers. Like, for example, when we started talking of respectful maternity care, there was denial of even accepting there's a prevalence of disrespect and abuse. And then there was, of course, the normalization. Young doctors and nurses said that, oh, you mean it's disrespect to do a vaginal exam without telling her what I'm doing? We never realized this is disrespect. And really, so what we need to do is, whether it is in the pre-service curriculum or when they are in service, we really have to introduce and really stress and emphasize some of these concepts, because like I was saying in my previous speech, that if you do not really pay disrespect and abuse enough attention, it would lead to women not taking up services. So I think that we need to invest more in helping health workers understand and again be able to provide better interpersonal communication, be more sensitive, understand social inclusion, look at equity with a different lens. So I don't think we're really training or even supporting our health providers to do that. So that's one part of it. I think the second part is, it's really important that these elements show up in policy, because if it is not in the policy, it is not in the program, it is not in the budget, and it will not happen, right? In addition to policies, it needs to feature in as indicators. So, do we have indicators for, again, let's say respectful maternity care, when we are designing our quality assurance checklist, right? So beyond policy, how do you really ensure that this happens? And lastly, I think both for providers and for women, systems to log in and understand and redress grievance is really important. I think right now things are happening. Women are going back home. Doctors don't know how they can really improve. So a system where it's a safe place for women to talk about it, for health workers to understand and then address it. So I would say these are maybe some buckets of areas where one can invest in. in order to support health workers along the way.
Thank you so much. My next question is to my colleague Dorit Steen. When we focus women and when we focus so many deliveries in higher level and higher quality facilities, what that also means that there is an increased demand. And traditionally, how providers have then met that demand is by increasing interventions. They have to deal with the volume of women. That might mean, unnecessary augmentation of labor, instrumental deliveries, C-sections. How do we ensure that when we are trying to improve quality, that this aspect of quality of care is also met when thinking about redesign?
Sure, thanks for that question. In our survey in Indonesia specifically, in the hospitals that we sampled, we saw actually an increasing C-section rate from 2014 when national health insurance was implemented to 2018. So there was an increasing proportion of deliveries that were done by C-section in our sampled hospitals, increasing by about 2% each year within hospitals. And then when we looked at the case payments for C-sections, the health insurance payments for C-sections were higher than for normal deliveries. So there's an obvious incentive there for providers to favor C-sections for fiscal reasons and also for the reasons that you just mentioned in terms of being able to schedule delivery and get women in and out when they want. And these things can contribute to supplier-induced demand and overprovision of services. So within a financing and payment framework, it's important to make sure that there's not incentives to over provide at the hospital level.
Thank you so much, Nora. We have one question regarding our current circumstances with the COVID-19 pandemic. Has the pandemic made primary care-based obstetric services more strained and difficult to access, suggesting higher level facilities will be more relevant, or is it the opposite? Is there anyone who would like to take this question? Or maybe more than one person? Maybe Dr. Morgan?
Yes, I can come in. The GFF did a whole lot of routine phone surveys of hospital facilities every 3 months over the last year across countries in Sub-Saharan Africa. And the Nigerian data, what was really telling was that very early on in the pandemic, there was less access around going to hospital for maternal care, primarily because of the lockdown or the fear, rather than, but that returned pretty quickly. And then some of the other services have been strained over the time. So what we saw by the third survey in December was that postnatal care had dropped by something in the order of 75%. So women are coming in, they're not being allowed to move around, they're not being allowed to, they're being often put in one room and they have to birth there as well, and then discharged quite quickly to try and avoid movement and try and care for COVID concerns, but causing some challenges in providing respectful maternity care. Many hospitals initially refused to have companions with women during birth. In some settings, there was separation of the mother and baby. So there was a lot of poor respectful care seen. I think that has changed. People are becoming aware that that's unnecessary, but in terms of where women are birthing, in many of the countries that we've surveyed, women are still seeking similar levels of care now that those lockdown transport provisions are over. But the actual care they're receiving might have changed significantly. And I think this has ramifications around ongoing trust and willingness to go back to facilities.
And Dr. Gogo, any final words? I realize that we've come up across the hour, but any final comments from you, and we can wrap it up.
Yes, and very quickly, like Dr. Morgan talked about, so when COVID happened, at one end, you had the diverting of funds and care and health workers to tackle the pandemic. So obviously, the focus on maternal care, reproductive care is used for some time. And the other side was also women's own fear of infection. So we know we did a survey with 12,000 women in around August last year, and we knew the women themselves were a little wary and afraid of seeking care. Then, of course, when there was a lockdown, the fear of moving out. What will I do if the police stops me and kind of harasses me about why am I out here? But more important, I kind of directly to the question that has been put on the chat box. For me, I think it's really important to reiterate the fact that maternal health, reproductive health should be part of essential health services, and to tell women what kind of services are available at which level, so that they don't really, go from one end to another end. And if we really want to push them to higher level facilities, then we need to ensure that are we sure that the referral transport is kind of catered to? Do we know that women can actually afford to travel further to go to higher level facilities? Are we sure that families would be able to take care of women when it comes to implication of of accessing facilities that are not closer to home? Because women tell us that if the facility is closer to home, the costs go down. It's easier on the families, it's easier on them. So I think this is an ongoing debate element.
Thank you so much, and thank you to all of the panelists. I feel we barely scratched the surface of this discussion. This is something that we've started today, but needs to continue because women and their children depend on it. I cannot emphasize the importance of ensuring that policies are created with women at the center, with women's voices at the center, so that they may best serve them. I also want to thank the Health Policy Plus project for hosting us today and for the support that the United States Agency for International Development provides. Thank you everybody for joining. We've really enjoyed the discussion. We hope you did as well, and looking forward to seeing your comments on Twitter. Goodbye, everybody.
Thank you.
Goodbye.